students might have an understanding of what is a acid-base imbalance, but I'm going to focus a little bit on the so what and how to identify and what to do with some patients who have acid-base imbalances. I mean, who's at risk for one? How do you know if they have one? What are you going to do to fix it? That's what we're going to cover in today's PowerPoint. Okay. easier. Here we go. This is a little example of what the values on somebody's ABG will show if they have metabolic acidosis. You kind of know why it happens, but their pH will be low, showing that it's definitely acidic. Their bicarbonate is definitely not enough, and so it's less than our 21 to 26 value. Well, I'll say this. I think I taught you guys 22 to 26, but it's on the lower end. Our oxygen on the blood gas will probably be normal. Metabolic acidosis is not exactly associated with hypoxia, but you know, I'm not going to say it's never associated with hypoxia, but we're going to see a normal oxygen level. And here our CO2, if a person has uncompensated metabolic acidosis, you'll see that it's normal. If you see the CO2 drop, meaning it's trying to compensate, we're probably going to have partially compensated metabolic acidosis. Now, this is kind of interesting, your serum potassium. When you have acidosis, regardless if it's metabolic or respiratory, your potassium's going to go up. That happens when the body recognizes all of these hydrogen ions inside the bloodstream, and so it naturally will kick out the potassium that lives inside the cells out into the bloodstream, and it will absorb the hydrogen ion. It tries to do this exchange, which we thank the body for trying to rid itself of the hydrogen ion. However, there is an organ that absolutely hates having high potassium, and it is the heart. Yep. If it's too high, heart's not happy, and you'll have arrhythmias. This is the more popular of the conditions, the blood acid-base imbalance conditions, probably because it happens a little bit more rapidly and a patient can develop it more quickly. So in the hospital, this would be a common finding that you are going to see because a lot of situations can lead to respiratory acidosis. In general, we have a respiratory problem, and it is impacting our CO2 elimination. And when I say elimination, I also mean retention. They're kind of synonyms. So when I'm retaining CO2, I'm also having a problem eliminating it. So I have under elimination. So I'll use the words interchangeably. Just keep up. All right. A couple of different reasons why we are going to retain CO2. We can have a chemical respiratory depression, or we can have a mechanical respiratory depression. What I mean by that is, what is a drug that we give patients often in the hospital that can cause this respiratory depression? Chemical, problem. Opioids? Correct. And even anti-anxiety agents, sleeping aids. So these medications chemically are going to tell our brain to relax. We're not going to be able to stimulate the diaphragm like we normally do to breathe, and the body by default is not going to take good deep breaths, and unfortunately we're going to start retaining our CO2 or under eliminating it. So that is one cause of respiratory acidosis. Now I mentioned chemically, but I also mentioned mechanically, or even if you want to think of it as physically. How about somebody who is a diver, and not the kind that wears a scuba tank, but they dive into a shallow pool, and if they have a neck fracture, maybe of the C1 or C2, the cervical spine there, their body will not be able to translate the signal down to breathe, take that breath to the lungs and to the diaphragm. So they're going to, by default, have respiratory depression. There are tumors also that can be in the brain, maybe somewhere at the cerebellar area, the bottom of the brain. If the tumor is compressing on nerves, somebody won't know to breathe because they're not getting that signal. Other things that I'm thinking of, believe it or not, overhydration can cause respiratory depression. So what? Ever heard of water intoxication? Basically, somebody has that's not a word. They have drunk, nope, have drinked. Wow. They consumed so much water that they actually dilute the sodium inside their body, and the cells in the brain can swell, and just by them swelling, they're going to be compressing nerves that innervate the lungs to breathe. So, yeah, water intoxication causes respiratory depression. It's a long train of thought there. Other things, mechanically, stroke, I already mentioned brain tumor, neck fracture, hemorrhage in the brain. Yeah, okay, that's where the control center is, so you can figure the rest out. All right, inadequate chest expansion. How about somebody who's in a trauma and blood starts filling up in their thoracic cavity or in their lung cavity? How are their lungs going to expand and exchange oxygen and expel CO2? They can't, so it's going to build up in our bloodstream, and it builds up quite quickly. So they develop respiratory acidosis. Can anybody say chest tube? Trauma is one. A pneumothorax. Some tall patients have problems with pneumothorax, meaning air gets in the space between their lungs and the lung cavity, and if your lung can't expand, there you go. Something constrictive. Airway obstruction. Anywhere from the mouth all the way down at the alveolar level, we can have air obstruction. Maybe it's mucus from COPD. Maybe it's asthma and they have really bad edema. Hey, maybe it's a kid and they swallowed a toy and it's stuck inside their throat or their mouth somewhere. All of them are developing respiratory acidosis, which, as you can probably guess, how quickly does it take for them to stay obstructed for them to probably have a bad outcome? Don't take long. Don't take long at all. Your oxygen goes down, your CO2 goes up. But how about anaphylaxis? That's a airway obstruction problem. I'm trying to think of all these different things. Somebody who has neck surgery. That's a little bit of an external airway obstruction. Strangulation, geez. All these sound pretty morbid. I'm sorry. All right. Lastly, if we can't get out the CO2, the reduced alveolar capillary diffusion, this is all what, when I explain this, I mean the blood circulating to the lungs. Maybe somebody has a really severe pulmonary embolism, so they threw a clot that went all the way into their lung bed and blood just can't get around it. And so blood can't get get to the lungs to get rid of the CO2, it's going to build. The other thing, maybe pulmonary edema. We got somebody who has heart failure and the lungs are so congested and the blood's not moving forward. It's kind of hanging back from left-sided heart failure from the pulmonary edema. We're going to have CO2 problems there. So a lot of different reasons can cause respiratory acidosis. It develops quickly and somebody can die from it. I would say this is probably one of the most lethal acid-base imbalance. All right, hallmark, when you look at a blood gas, you're going to see their PO2 or their oxygen level, which is normally 80 to 100, be less. You're really dangerous if you're in the 60s. I think the lowest I've personally ever seen was 46, and that person did not make it. And then with the rising CO2, meaning it's greater than 45. Person's getting more and more acidic. Okay. I think that's all I need to say on this one. What is our blood gas going to look like? How am I going to know if this person has respiratory acidosis? Besides kind of understanding the person's situation, such as they had a hip fracture and I just loaded them up with a whole bunch of morphine, besides kind of looking at that data, you can grab the blood gas and you're going to see that their pH is low. Just like metabolic acidosis, it's going to be less than 7.35. You're going to see that the person is hypoxic. If you remember, on metabolic acidosis, they're probably not going to be hypoxic at all. For respiratory acidosis, yes. Listen to me, I'm saying yes. So that is a yes. Their CO2, it's going to be greater than 45. We're going to see it up there because it's being retained. It can't get out of the body for one reason or the other. Their serum bicarbonate, it kind of depends. We may see compensated bicarbonate where it's actually going to be greater than 26. We could see that it is uncompensated where it's going to be in our normal levels, which is 22 to 26. So it's going to kind of vary. Now, like I mentioned earlier, our acidotic states expect a high potassium level. Expect the high potassium level. So if I say treatment for any type of acidotic state is giving them potassium, you're going to say, heck no, Miss Tonis. No way, no how. No way, Jose. All right. For patients who are chronic COPDers, so they've had COPD for a long amount of time, we're actually not going to see our potassium go up because the body's gotten used to having high CO2 levels. It's gotten the pH back into the normal level, and our potassium is not going to actually show us that it's high. So you can't exactly determine if somebody has respiratory acidosis by looking at their potassium level exclusively. It's kind of a big picture there. All right, good deal. Well, your patient came in with pneumonia, so what? Well, your patient also came in with high blood sugar, so what? Oh, your patient also came in with maybe a UTI and is on antibiotics. Well, so what? Well, maybe that person's not going to breathe so good with pneumonia. Maybe that person with that high blood sugar could be developing DKA. Or maybe your person with antibiotics because of the UTI could have excessive diarrhea. How would you know if they're developing that acid-base problems? Outside of taking the blood gas, you're going to see some changes on that person. One of the first changes you're going to see is their behavior. In fact, this is what's important in that initial conversation you have with your patients, is getting a baseline so you know from the get-go, all right, they're a little quirky, or maybe they're confused, or maybe they're completely alert and oriented. So this will allow you to detect a change if it were to happen, because a behavioral change is one of the first things that are going to occur when you have an acid-base problem, particularly when I mean acid-base problem, acidosis of either origin. If your person has, say, a coma, or they're in a comatose state, they're probably a little late along the lines. They're stuporous. They're completely tired. We're way past that restlessness or behavior change early in acidosis. By this point, you may have to do some serious interventions. Muscular-wise, they're going to be extremely weak and flaccid. Their deep tendon reflexes are going to be poor, or we say their person's going to have hyporeflexia. Their muscle tone, as I mentioned, flaccid. They're not going to be very strong at all when you ask them to squeeze your hands or to push your fingers away whenever you check their feet, or even lift their legs off the bed. When you grab vital signs, you're going to see that the heart rate is elevated. Their blood pressure is going to start having some changes from their baseline. It may be a little bit lower, and the person is going to have decreased activity and tolerance. So they're not going to be able to get from here to there as easy as they used to be able to. If we continue to watch that patient and we don't provide an intervention, they're going to develop hyperkalemia. And if we have an EKG on them, which is one of the interventions you will do, you're going to notice that their T wave is extremely high and their QRS is really wide and kind of bizarre looking. We are going to learn EKGs next semester, but for right now, you just have to remember the T wave and the QRS is going to be changed. If you were to check their peripheral pulses, they're going to be weak and thready. our perfusion is starting to really tank at this point because of the acidosis. Now, our respiratory changes that are noticed are going to depend upon what is the acid-base problem of origin. So let's just say the person overdosed on aspirin, or maybe they have really chronic kidney failure, whatever it may be. They have metabolic acidosis, and you're going to notice Kussmaul's respirations. This is respirations that are deep and fast, like somebody just ran a marathon and they're like that is the body's natural compensation to their underlying problem. So the lungs are trying to expel the CO2 because the kidneys aren't, or the fact that the person overdosed on aspirin and the body knows it has to get rid of those hydrogen ions, which it can in the form of CO2, getting that lowered. So you'll see Kussmaul's respirations, which are a compensatory mechanism of the body for metabolic acidosis. So it's a compensation. Now, that's deep and fast. What if our acidosis was because we have a lung problem? We have pneumonia, we have COPD. If those are the cases, we are probably going to see shallow and rapid respirations. They just can't get enough air in, so they're going to be shallow and rapid. Or you can have the person overdosed on pain pills. Maybe the nurse actually gave them too much pain pills. They're going to see shallow and slow. So you could kind of see either or on the respiratory system, whether it's tachypnic or they'll have slow respirations. Could be either or here. But please know that Kussmaul's is the compensation, not the actual problem. And these are always deep and fast. Got it? All right, skin changes. For either or, they're going to get a little pale. They're going to get diaphoretic on you. Cyanotic, you'll notice it in their fingers. You're going to notice it in their mouth maybe. It's kind of related to the hypoxia that may ensue with respiratory acidosis, but with the metabolic, they can get pale. I've also seen patients that have dry skin and it's warm and they just have a flushed appearance. So I'm probably going to say it depends what their skin's going to look like. Psychosocial assessment, just be detecting their behavior changes, such as were they confused originally and now they're worse? Can they even open their eyes? Is their behavior aggressive and restless now? Those sort of things. An important intervention that gets missed a lot is implementing fall precautions. Your patient is not only confused, but their cognition is impaired, meaning they won't understand how to maybe call for help, or that they can't get out of bed without assistance. They're not able to perceive that they are weaker now because of the acidosis, and they're going to be hypotensive, unfortunately, as well. So we have hypotension, we have impaired cardiac output, we have weakness, behavior changes. All of that says put a bed alarm on. Make sure the bed is in low position. Maybe have a sitter if this person is super, super high risk. The next thing we want to do is hydration. That really doesn't sound like an important intervention, but it is. Hydration. And the two reasons we're going to do hydration is to dilute the blood and to flush the blood. We need to try to disperse the hydrogen ions, and we can do so by administering normal saline to a patient with metabolic acidosis. Now, please pay attention. There was one problem with metabolic acidosis that is caused by overhydration. Do you remember that water and toxicity? For that person, you actually have to put them on like 3% saline, not that 0.9% saline that we're used to infusing. So hydration is very, very beneficial, but I will say the type of hydration that you use is critical. So we have to know our underlying problem so we can treat it appropriately. Drug-wise, we're going to be giving somebody insulin if, say, their acidosis is from DKA. That insulin is going to finally open up those cells, allowing the sugar in, and the body's going to quit breaking down those keto acids, those fat cells, which result in keto acids, actually. If, say, they're on, I don't know, an antibiotic and it's causing diarrhea, you can either switch antibiotics or maybe administer antidiarrheals. A couple different options there. Sometimes it's chemo-induced. Can't really stop the chemo, need to kill the tumor, so we're going to give them antidiarrheals. How about sodium bicarbonate? Let's give them some. We can infuse this two ways. We can IV push if we're in a code situation. Maybe their lactic acid is super high because they have overwhelming fever due to sepsis, and one thing you can do is to help reduce their metabolic acidosis by pushing sodium bicarbonate straight. You give them one big old glass ampule full of it, about 50 mLs. Or say their metabolic acidosis is due to kidney failure, chronic kidney failure. Well, they don't make enough. We don't need to push anything on them. We just need to have sodium bicarbonate mixed in some saline and infuse it slowly. Other ways we can help is give patients sodium bicarbonate tablets. Like literally, it's baking soda compressed into a tablet, and a patient will take it like 3 times a day. That's something that can help. I already mentioned for our aspirin overdose, giving them charcoal, activated charcoal. That's only for that situation. That's not a typical intervention for metabolic acidosis. All in all, you can see how specific it is to the cause. Treatment for respiratory acidosis is a little bit more, how do I say it? It's harder to define because there's so many different reasons that can cause respiratory acidosis. If you think back to some of the different problems that can result into this, we have maybe asthma. So what it would be a treatment for asthma? How about albuterol, maybe corticosteroids? How about anaphylaxis, where somebody's throat closes up? Well, I don't think albuterol will do us much then. We'll probably need to give that person epinephrine, a steroid, Benadryl. Maybe somebody has heart failure and they develop that pulmonary edema. Well, at that point, you're probably going to give this person a diuretic. So there is a variety of treatment methods for respiratory acidosis, and it all kind of boils down to what the problem is. But if I say maybe opioid overdose, they took too much morphine or something, what would you say would be a good drug therapy that would be appropriate for them? Maybe Narcan, the reversal agent? That would be correct. Or naloxone. So as you can see, it kind of varies. But med-wise, we can give albuterol, we can give anti-inflammatories if they have, say, COPD problems. We, for COPD, can give Mucinex, also known as guaifenesin, that helps break up some of the obstructive mucus. Maybe we can give that person Lasix or furosemide. Oxygen. Oxygen is extremely important. We want to keep their SATs greater than 92 preferably. If they're a CO2 retainer, we'll let them go down to about 88%, but no less than that. Try to give them the lowest amount of oxygen possible. So we usually start at 2 liters, work our way up to 3, 4, 5. After 6 liters, most of the time you can transition to giving somebody a Venturi mask or a Venti mask. When somebody has a Venti mask, you then measure in percents versus liters. So somebody on a Venti mask would be on, say, 35% oxygen or 40, 50. And hopefully we don't get to the point where we're on a non-rebreather, which would be 100% oxygen. Worst case scenario, give notes down here, we can put them on a vent if their respiratory acidosis is not improving. A personal situation where my family member overdosed on what they thought was cocaine, but was actually fentanyl, a potent narcotic. My family member was unable to recover with just Narcan, with just oxygen, and so they had to put them on the vent, and the vent would actually breathe deep enough for this person because they were so heavily sedated. And yes, you can put oxygen and hook it up right to the vent, so they're getting oxygen through the vent. Let's see, pulmonary hygiene, also known as pulmonary toilet. I don't know why they call it that, but they do. Sometimes that's how old doctors want to refer to it. Can you please perform a pulmonary toilet? It's like, sure. What that means is have the patient turn, cough, deep breathe. They must use their incentive spirometer about 10 times an hour. Their positioning needs to change. They need to be, sitting up in a chair. They can lie down, but, try to get that person moving and move the secretions around. We can perform percussion on that person, try to get the mucus broken up, or using one of those flutter valves to help break up the congestion in their lungs. All right, so that would be pulmonary hygiene. Frequent assessment. We need to be in there probably every hour checking on a patient who has respiratory acidosis. Is their behavior improving? Is their tachycardia going away? Is their oxygen actually coming up? Are they getting less tachypnic or even having a low respiration, depending upon what it would be? More than likely, you are going to have a Holter monitor on them or a ambulatory EKG, so you can see if they have improved their EKG rhythm, which probably have shown or reflected hyperkalemia. The wide NQRS and tall T waves. Good. Metabolic alkalosis has a few different causes. One would be excessive intake of bicarbonates, particularly sodium bicarbonate. So a patient would be treated for, say, metabolic acidosis by getting an infusion of sodium bicarbonate. Lo and behold, we can go to the other extreme by giving them way too much. So we have to watch their levels to make sure this doesn't happen. Also, this other carbonate here, it is part of calcium carbonate. If you think to an over-the-counter medication for, say, heartburn, what has carbonate in there? How about calcium carbonate, Tums? Having too much Tums or too much calcium carbonate can actually have you develop metabolic alkalosis. Acetates and citrates, these are additives to blood products, such as red blood cells. A patient could actually develop from multiple transfusion metabolic alkalosis. We always have to be watching out for that. Acid deficit is another type of metabolic alkalosis where we don't have enough hydrogen ions. Some way, somehow, they're being sucked out of our body or, pulled out of our body. I guess that sounds the same, doesn't it? Pulled and sucked out. Pulled meaning some patients who receive chemo have a horrible side effect of vomiting, and they're vomiting and they're vomiting. And what is in our gastric contents? What's in those juices in there? Maybe a whole lot of acid. Yep. We can actually throw up so much that we put ourselves in an acid-base imbalance. Now, a lot of patients don't have problems throwing up, but they just had bowel surgery, and we have to decompress their stomach by sucking all of the contents out of their stomach so their intestines can heal a little bit faster and not have a pressure or leak or blah blah blah. That prolonged NG suction can also put that person at risk for developing metabolic alkalosis. The other things that can come up are thiazide diuretics. They make you waste your hydrogen ion out, and same for hyperaldosteronism. I believe this is material that will come next semester, but for now, you will hear it here. Let's move on and talk a little bit about metabolic alkalosis, or I should say alkalosis in general, and we're going to cover metabolic alkalosis first. So this, once again, is a manifestation of a problem. It is not a true disease. To treat this condition, you need to figure out what the problem is, whether it's, metabolic reason or respiratory reason, and fix this so this person's pH can return to normal and this person no longer has to have this state of being in metabolic alkalosis. So it can result if, or one in two ways. You can have too many bicarbonate ions, and your hydrogen ions can be completely normal, but your bicarbonate ions either are overproduced or they're under-eliminated. In cases where they are overproduced, one example could be excessive antacid ingestion. I've had one patient who had such severe heartburn that they continued to take Tums, sodium bicarbonate, and just after a period of weeks of doing this, they actually developed metabolic alkalosis. So that person had too many bicarbonate ions and not enough hydrogen ions to be normal. Another reason that somebody could have metabolic alkalosis would be receiving transfusions of sodium bicarbonate. As we mentioned a few slides back, some of your renal failure patients might have to have a transfusion of fluids mixed with sodium bicarbonate. Now, that is given to treat metabolic acidosis. However, if you're not closely monitoring the patient, and for one reason or the other, their bicarbonate level will start rising and nobody stops the IV fluid infusion, you can actually put your patient into metabolic alkalosis. So receiving transfusion of sodium bicarbonate increases your chance for metabolic alkalosis. And the acetates here, that is in the citrates, those are in blood. Whenever they put when they prepare blood, it's one of the preservatives. So if you have somebody who's receiving multiple blood transfusions, you do have to check them out for metabolic alkalosis, and we'll talk about signs and symptoms of that in just a slide or two. The other type of metabolic alkalosis that we have is acid deficit. This is also, or mainly, it's called relative alkalosis. So you basically have a normal sodium bicarbonate level, however, the deficit is with the acid. So this causes an imbalance, and it results from over-elimination or an underproduction of acids. It's happened, in fact, on my watch multiple times, because somebody has, on the chemo floor, prolonged vomiting. They're throwing up what's in your stomach. Acid, lots of acid. So throwing up all of the stomach contents multiple times can actually put yourself in an alkalotic state. And prolonged NG suctions. So your patients who have, say, small bowel obstructions or have had bowel surgery, the sooner that we can get that turned off, the better, because they need that acidic gastric juice. Let's see. And hyperaldosteronism, there's going to be a couple of different reasons that cause this disorder here, but the main thing you know is in this disorder it makes your potassium be depleted out through your urine. So with potassium down, you have a higher incidence of having less hydrogen ions. So that's that relative acid deficit. So anyway, that's good to know. Oh, and same for thiazide diuretics. This depletes your potassium, and so it will relatively deplete your hydrogen ions as well. So. And if you look at a basic ABG, you'll see these kind of results whenever you try to determine if it's metabolic alkalosis. pH will be elevated, so greater than 7.45. Your bicarbonate will be up. I believe your book says it's 21 to 28. I will say check your institution policy and what it defines as a normal level. I know at the hospitals I've worked at, they say 22 to 26. So just see what your hospital says. Anyway, and the O2 will be normal and the CO2 level will be normal, okay? The last acid-base imbalance we need to discuss today is respiratory alkalosis. The primary problem that results in respiratory alkalosis is hyperventilation. This could be due to anxiety, fear, maybe the vent settings are set to a patient's breathing too fast with too much volume, so we need to dial it down a little bit. Or it could be due to fever and salicylates. Wait a second. Salicylates, I remember that was one of the causes for metabolic acidosis. How could it also cause respiratory alkalosis? Well, great question. Believe it or not, but when the body gets an overdose of aspirin, it can actually try to help itself in the moment, and it will have the patient breathe extremely fast and deep, and believe it or not, the body can put itself into respiratory alkalosis, the exact opposite, and now we have a respiratory problem where originally we had a metabolic problem. Kind of crazy to think about. I do want to note one thing. Students get mixed up a lot about the hyperventilation being the cause of respiratory alkalosis and Kussmaul's respirations being the compensation mechanism of metabolic acidosis. Do know that both of these, Kussmaul's and hyperventilation, do result in the patient breathing deep and fast, but one is the problem and the other one is the compensation of the problem. Keep that in mind. The signs and symptoms of alkalosis look very similar regardless if it's of metabolic or respiratory origin. Your patient's going to have two primary electrolyte imbalances, the first one being hypocalcemia. Their calcium is going to be too low. Wait, I thought the person had an excessive intake of calcium carbonate and that can cause metabolic alkalosis. You are correct. However, there is a sometimes not always clause I would like to put inside here, but in general, suspect that your person has hypocalcemia. And with hypocalcemia, we're going to have the reports of numbness and tingling around the mouth and on the tongue and on the tips of somebody's fingers. That is usually a first sign of alkalosis. With hypokalemia, your person's going to report some palpitations and even some tiredness and weakness. If we were to check this person's neuromuscular status, they're going to be very twitchy and have hyperreflexes. So if we were to tap their knee or tap, say, their brachial reflex, we're going to show a hyper response. CNS-wise, they're going to be irritable. Your person may have some behavior changes, and they are going to have a positive Vostick sign and Trousseau sign. You can follow those links by holding the control button down and clicking it. Those are YouTube videos of how to test for Vostix intruso sign. This, if the person does have a positive Vostix sign, is their face is going to twitch when you tap on the facial nerve. And for Trousseau sign, you put a blood pressure cuff on their upper arm and you squeeze it tight, and their arm is going to curl up as tight as it can get, as tight as the hand can get. This lets me know that my patient is suffering from hypocalcemia. If we don't catch this person's problem and it gets worse and worse, the patient will probably go comatose on us and or develop seizures. If they develop seizures, that's usually a bad and poor sign. For cardiovascular changes, we are going to notice that they're going to have some tachycardia, hypotension, and have a weak, thready pulse. Respiratory changes, primarily their rate is going to be fast, and this is likely due to the anxiety or fear that the patient may be having if it's of respiratory origin. Like acidosis, your interventions are very dependent upon what the problem is. And your medications are going to differ as well in what you're going to try to treat. So if our patient has metabolic alkalosis due to an over-infusion of sodium bicarbonate, one of your interventions is going to be communicating with a doctor your signs and symptoms and probably discontinuing the sodium bicarbonate. If we see that the patient has a positive Vostix sign, we need to infuse some calcium into their veins, either by adding it to a solution or through an IV push, so we can give patient calcium. The patient will more than likely get fluids to help dilute and buffer and try to wash their system out, so we're going to give them some IV fluids. They are a safety risk primarily because of the numbness and tingling. They'll even complain of just paresthesias, like feeling having that tingling feeling in their feet. So they're not going to be very safe when they get up and move. So we want to make sure they are on fall precautions. If they do have a problem with vomiting, we want to make sure to give that patient an antiemetic, meaning like Zofran or Phenergan or Compazine, something that's going to help them not throw up their gastric contents. If they're on suctioned, like they have a nasogastric tube and it's decompressing the stomach and sucking contents out, if we're at a point where we can discontinue that, let's go ahead and discuss that with a physician. Remember, diuretics was also something that can make a person lose their hydrogen ions as well as their potassium. Well, let's go ahead and change diuretics, or maybe just replace them with potassium. We can give them the diuretic with the potassium or with calcium. It really just kind of varies. A lot of times patients who have respiratory alkalosis, we'll give them an anti-anxiety agent, or if you want to do non-pharmacologic, you literally will give them a bag to breathe into. So as they breathe really, really fast and try to hyperventilate, with that bag, they will actually breathe back any CO2 that we could possibly use inside the body. So giving them a bag, changing the vent settings, there's a lot of different things that we can do, but it all depends upon the patient's cause for alkalosis. Lastly, here's a quick little question for you, and if you want to know the answer, you can complete the slideshow and it is at the bottom. Thank you so much. Have a great day.